Good evening. I'm Dr. Robert Peppercorn, and this is the Yuba Sutter Medical Explorer. As a specialist in skin diseases and allergies, and as host of this program, I will take you on an exploration of the medical communities of Yuba and Sutter counties and bring you behind the scenes of medical care practices right here in our local area. I have a very interesting and quite useful program for you tonight as we continue to explore a subject that seems to constantly attract news headlines. This is the subject of cancer. Tonight we will examine a type of cancer that recently received great publicity because of its effect on the President of the United States. Our subject for this evening is cancer of the colon and rectum. As part of tonight's exploration, we will meet our area's most experienced specialists in the area of diseases of the gastrointestinal system, and also have the opportunity to take a close look at the tools that he uses to diagnose hidden cancers of our intestinal system. This is an extremely interesting and very important subject, and I hope that you'll stay with us for the next half hour. Before getting to our topic tonight, let's take a look at the latest medical news. It looks like more bad news for the Type A personality. Type A women under stress, like Type A men, are at a higher risk for heart attacks than Type B women, a new study suggests. Nearly all research so far on Type A's, competitive, aggressive people, has been on middle-aged men. When given challenging tasks, Type A men's heart rates jump significantly higher than do easygoing B's, putting them at greater risks for heart attack. It's also been found that Type A women are more likely than Type B's to drink excessive coffee and to smoke, to be overweight, to exercise less, and to feel angry more often. Type A reaction may be part of an overall coping style for challenge, a catalyst in a set of negative health behaviors that increases risk not only for heart disease, but for other diseases as well. Although employed women are more A-prone than homemakers, a study of 95 middle-class housewives found plenty of Type A's. They do more volunteer work than B's, overly commit their time, and report much more stress. And like Type A men, these women are more likely than B's to be unhappy in their marriage. The Type A urge to be dominant, competitive, and independent may hurt marital harmony. Next in the medical news is more information about skin cancer. The risk of developing skin cancer is greater for people over age 50, but a new study of women golfers suggests that skin cancer can occur at half that age when sun exposure has been heavy. Researchers evaluated 193 women, 51 professional golfers, and 142 who played golf for fun. The pros, whose average age was 28, were exposed to 5 times as much sun as were the amateurs, average age 54. And surprisingly, they were just as likely to develop basal cell carcinoma, the most common type of skin cancer, and the type that was recently removed from President Reagan's nose. Dermatologists are used to seeing basal cell carcinoma in men and women in their 50s and 60s, but more skin specialists are now reporting these cancers a full 25 years earlier. Fortunately, basal cell carcinoma of the skin is usually curable if caught early. My final medical news item brings us new techniques to repair torn ligaments. Synthetic materials may soon be used routinely to repair torn knee ligaments, one of the most common sports injuries. It seems very likely that we will see the role of synthetic ligaments increase tremendously in the next 5 to 7 years, according to a professor at the Boston University Medical School. Knee ligament tears are the most common injury among amateur and professional football and soccer players and skiers. The success rate of knee ligament surgery, usually a durable cloth, ranges from 70 to 90%. Doctors say that the procedure can prevent arthritis and future ligament tears with this artificial synthetic material. Meniscus injuries of the knee are also being successfully repaired with artificial materials. Now, on with the Medical Explorer. Most of us don't even think about the important functions of the gastrointestinal system of our bodies unless something goes wrong. We all occasionally experience common GI symptoms such as indigestion or a stomach ache. However, the disease of cancer of the gastrointestinal system can occur without any symptoms whatsoever. Our special guest tonight will tell us more about colon and rectal cancer. He is our area's most experienced specialist in the field of gastrointestinal diseases and he also specializes in the area of internal medicine. Let's leave the studio now and travel over to the Fremont Medical Plaza in Yuba City as we meet Dr. Ralph Breitenstein. Dr. Breitenstein, the American Cancer Society, as you're well aware, constantly suggests the use of preventative testing for cancer. Is there a screening test that can be done to look for cancer of the colon or rectum area?
There are several screening tests. The one that is the easiest and most inexpensive to do is a measurement of the stool for blood. And we can measure blood chemically in the stool in far smaller quantities than one can see it with the naked eye.
So in this case, does a doctor have to do this, or is this something that I've even heard about screening programs through drugstores doing things like this?
During the last year or so, the pharmacology companies have come out with these little hemoccult slide tests that are available in any drugstore.
Oh.
And we use these with our patients, and they're very, very simple to do. We normally put the patient on a diet that's red meat free, because if you eat raw steak, it's going to come through and give you a positive stool. Right. So we either have them eat their meat well done, or eat fish or chicken, and a lot of roughage in the diet so that they're not constipated and cause trauma or irritation to the rectum when the stool comes out.
Skin. Sure.
That's right.
Sure.
And we ask them to be a little bit careful when they brush their teeth, because if you brush your teeth very hard, or if you have a bloody nose during the period of time when we're collecting the stool, that will give you a false positive test. But basically what the patient does is that in the privacy of your own bathroom, you open up the one side, and we supply a little stick that looks like a popsicle stick, and you take a little piece off of each end of the stool, and you smear it on. Now, for demonstration purposes here, we have had a generous donation of blood so that this will approximate the stool.
So we can just imagine here that there's a stool here.
This would be a little brown
blood in there.
A little brown bit of stool on each section there, and the patient then closes it up. They then give it to us. We open the back side, and
let me just hold that like that.
We put a drop of blood of the developer on both the stool, and you wait about 30 seconds.
I can already see some color.
As you can see, if it turns blue, which it's beginning to do, that means that it's positive for blood. Now, the little orange line at the bottom has one positive control that should be blue and one negative control that should remain.
Just tells us the test is working.
That tells us that the paper and our reagents and everything are fine. And this test is less than $20. How much less depends on where you get the test done, and it's quite sensitive. Although there are false positives and false negatives, this is the first test.
So it doesn't mean definitely if it's positive that the person has cancer.
That's correct. It just means that there is blood in the stool, and that can come from anywhere from brushing your teeth to ingestion of raw meat or virtually anything.
Right. So it's a beginning. It's a point to start.
This is a beginning. If we get a positive test here, then we proceed on to the next series of tests.
What would be done if a general physician or an internist wants to look for cancer? Let's say they've done this test, you're not the physician, someone else might be the physician, and they don't have the advanced equipment you're going to show us in a few minutes. What are some other tests that they could do for the patient before they get to the more complex testing?
Usually there are two tests that are done. One test, depending on the patient's symptoms, is the barium enema, because we're looking specifically for colon cancer. The barium enema is ordered by any physician and done through the outpatient x-ray department, and there's a routine prep, and I suspect a number of our viewers have experienced this. I've experienced one myself, and it was not as bad as I had anticipated.
People say there's a pressure feeling, I guess. Right?
It makes you feel like you want to evacuate.
Okay, great.
The other thing that is done, and this is a time-honored, sadistic method of evaluating the patient's lower intestinal tract, is with a lighted, flexible, a lighted rigid tube. Now this particular tube is called the sigmoidoscope.
Okay.
Okay? This is a straight sigmoidoscope. The patient will usually be on a table similar to this, and then you thrust this inside of the patient and basically go as far as you can within the limits of the patient's tolerance for pain. Now, physicians don't particularly like to do this because they hurt their patients, and the patients really don't like to have this done. So fortunately, the Japanese came to our, and American Optical came to our rescue about 12 to 15 years ago with the advent of fiber optic instruments. And this is what we're pretty much now has become the standard way of viewing the colon. This is a flexible sigmoidoscope. They come in different lengths. This is a standard 65 centimeter length that we use. The light source is a 150 watt bulb back here, and when you turn it on, and you'll see it, if you look at it, you'll pretty well blind yourself, so you don't want to look straight at it. But it gives you plenty of light to look as far down the colon as you can. The control knobs, now if you just hold this up here like this, I'll operate the control knobs. And this is the beauty of this. Through the flexible bundles, we can control and bend it into virtually any position. Now the colon is not straight, so what happens is that this tube will then conform to the patient's colon, and we can get about 3 times as far with this instrument as we can compared with the other instrument.
Oh, that is fantastic.
With much less pain. We can virtually always get as far as we used to get with no pain. The other advantage...
if you don't mind me asking,
go ahead.
Do you use this as more of a routine now for sigmoidoscopy on your patients?
I have switched to this completely.
Oh, have you?
And I have the trend amongst all of the physicians in town and across the United States is to use this in place of the rigid sigmoidoscope. For 2 reasons. We get further up and we can find more potential cancers and polyps, and secondly, the patients enjoy it. Well, not enjoy it, but
they don't suffer through it.
It's not as bad as the other one.
Now, can you actually take samples of tissue through this?
We can take samples of tissue, and we have a little biopsy forceps that is very, very small. We may want to get a close-up of this, but I will show you how it's done. This is a 2-person procedure, but it goes through, there's a little channel inside along with the light bundles and the control wires.
So we can imagine this is inside a person's...
This is in the patient, and as you can see, the biopsy forceps have come out here.
That's great.
We open the biopsy forceps.
Oh, you can really, just like little scissors.
Right. Sort of... We advance the biopsy forceps, pinch, and take the biopsy out, and we can take as many biopsies from as many sites as we want.
Is there any risk to this procedure?
There's virtually no risk to the taking of a biopsy. Back before we developed these small biopsies like this, there was a certain risk, but I think in all the years I've been doing this, I've never had a complication with this instrument or with taking of biopsies.
Are there certain people that should have this done on a routine basis, every year, every few years? What's the general feeling about that?
There's a little bit of a debate over how frequently to do this test and when to start. And in general, if the patient has a history of cancer in the family of the colon, say your father developed cancer at age 60, then we'd start looking at you at about age 50.
I see.
Otherwise, if there's a history of female cancer in the family, you're at a higher risk for this. If the patient has known polyps in the past on a previous examination, and I normally do this procedure when the patients are in their late 40s or early 50s as a first time on a regular basis, and if they're clear, then we do not do another procedure again like this for between 3 to 5 years. You do not need to have one of these annually because polyps by and large don't grow that fast. So you only have to do it about every 3 to 5 years, which is something people enjoy too.
You're not having it every year.
Right, you tend to forget from 1 year to 5 years later.
Now, in medical school, it was always stressed to me the importance of a doctor doing a rectal digital exam, just using the finger in the rectum. And we look at the length of a finger compared to the length of this.
Right.
You really can't get very much depth there with your finger.
That's correct. And over the last 20 to 30 years, the colon polyps and cancer seem to be migrating further away from the rectum up into the colon. Fortunately, technology has kept up with this. Right. I always do a rectal examination first to check. But with this instrument, what we do, if you'll hold this up there, we take and we basically hook a U-turn, so to speak, inside the patient, and if this is the rectum, I can look at the inside of the rectum.
Ah, yes,
too.
yes, coming out. You can,
and so we can get a look at both ends of the rectal sphincter.
Great.
This is, in my opinion, part of a complete physical and a screening as it relates to cancer of the colon and potentially pre-malignant lesions of the colon.
Great. We all heard the massive news stories about President Reagan recently and his polyps and cancer. Would this sigmoidoscope have found his problems?
This particular instrument would have found the polyps that they took off in, for example, the one in 1984 that they took off. And I believe they found the polyp with this instrument during his examination this year also.
I see.
It would not have found the cancerous polyp in the president.
So you have to go a lot further in.
We have to go further, and I'll show you the instrument.
Oh, great,
that we do that
great.
with.
Gee, we're getting a little longer here.
This is the big brother to the other one.
Okay.
This one is 6 feet long.
Gosh.
The principle is exactly the same. If you'll look at the end again, it is flexible and turns. The control cables and everything are longer. The colon is about 6 feet long, and with this instrument we can, with a high degree of success, get the entire colon visually examined.
Now, if the tools are this, I mean, it seems like someone like yourself who knows how to do this so well, this is a very straightforward procedure, probably a very simple procedure for you to do. Why wouldn't Reagan want to have done all this the first time, do you think?
Well, as I recall, they found the first polyp in the president during his examination in 1984, and they resected that polyp then. I suspect, in reality, what went on at Bethesda Naval Hospital was that the physicians came in. These guys are no dummies. They came in and they said, well, we should take another look at your colon, either with the colonoscope such as this or with the barium enema. And if I were President Reagan running for re-election, knowing I was 72 and otherwise healthy, and I might have said, well, what's the chance of it being a big problem in the next 8 to 12 months? And they would have said probably relatively small. I'd have said, well, let's just not bring this issue up. And I suspect Reagan was probably the one that said, no, let's wait until after the election, which is precisely what happened, and he won and did it after his election.
They probably did the right thing, to tell you the truth.
I don't think it will hurt his chances of survival, and I think he'll carry out his term without any problems.
How do you actually get pieces of polyps with this tool?
Well, we have another piece of equipment, which is called a snare.
Okay.
And what we do is this goes through...
Why don't we hold this up? So
yeah, just hold this up right here. And this is inserted just the way we did with the biopsy forceps through the tube. Right. Then we open this up, and as you can see, there's a wire loop that comes out. Now, pretend your finger's a polyp. What we do is we lasso through that thing, we tighten it down, and we apply some electrosurgical current, and we burn it off.
Cautery
now,
type
if
thing.
I had my cauterizer here, we could see a four-fingered dermatologist.
No.
But we won't do that here tonight. This cauterizes it and resects the polyp all in one fell swoop, and providing that you can get around the base. And this is a judgment decision that has to be made at the time. And when the physicians found with this colonoscope the polyp in the president, they felt they could not safely take it off. And this is a decision that I've had to make many times too. You look visually and take it off.
But you could get a sample at least to find out if it's cancer or not.
That's correct, and that's what they did. They used the long biopsy forceps, and then they went back the next day and did the segmental colonic resection.
Well, I've got some more questions for you about what would be done after someone is told they have cancer. Could we go back to your office and discuss these?
We certainly can.
Great, let's do that. After you've done your colonoscopy or sigmoidoscopy and performed that little biopsy, and a cancer is found, unfortunately, but it happens sometimes, what happens next to a patient?
If possible, we take it out through the colonoscope, because that involves no surgery. It's an outpatient procedure. Otherwise, the patient has a laparotomy where their intestine or where their abdomen is open, and we take out a little segment of the colon.
Now, would you do that work?
I do not do that work. I refer the patient to a competent surgeon for that type of surgery.
I see. Okay. Is it always fatal?
No.
Oh,
if it's found early and it's not spread into the wall or beyond the colon, the chances are 95 to 99% that it can be cured. Even if it's spread into the wall, the chances are still about 85% that it can be cured. And if it's spread into the lymph nodes, the chances are still are very good that it can be cured completely. So it's by no means fatal, although it can be if somebody ignores the problem for a long time and it spreads to the liver or other organs, such as the lungs.
I see. They really made a big deal about President Reagan and whether his cancer was in the wall, partway through the wall, going through the wall, and all that makes a difference, as you're saying.
That makes a big difference. And President Reagan's was in the wall. It had not spread to any of the lymph nodes, and the prognosis there is very, very good.
Let's say we have a healthy person who just wants to do everything possible to prevent cancer. Is there something that can be done now?
I think the most important, the only things we can really say that are pretty well shown to help prevent this are to avoid being chronically constipated, to keep your bulk and fiber in your diet up, and to cut down, generally speaking, on the intake of red meat, because there seems to be some carcinogens in the red meat that are not present in other forms of protein that may predispose to cancer.
Gosh, I love steaks. I don't know if I can get myself to do it.
You don't have to completely eliminate it, but it helps to not eat it 8 times a week.
Okay, good. Any other special diets? Does someone have to eat whole wheat bread, whole wheat this, everything, all bran, and etc.? Is that necessary?
Any way that you want to approach the situation. If somebody, for example, myself, I eat a salad a couple of times a day and it works. Other people take products in it from a drugstore, such as Metamucil or similar products. Other people sprinkle whole wheat bread or use wheat germ on their cereal in the morning.
So the main thing,
a variety of ways of doing it. They all accomplish the same thing.
Trying to avoid constipation with the stool product staying inside the body too long.
That's what we think makes the difference.
I should mention that your work is not just limited to gastroenterology. You have a busy internal medicine practice as well.
That's by choice.
Well, I just heard out there your nurse saying that you have a patient ready to be seen, so we better end our discussion now. I want to really thank you again for allowing us to come into your office and interrupt your routine here a little bit. It's really been a pleasure. Maybe I could convince you to come back on my program in the future and handle another subject in your area of work.
I'd be happy to.
Great. You heard him say that. Thanks again, Dr. Breitenstein.
Thank you.
If you would like more information on cancer of the colon and rectum, or just more information about cancer in general, then you should pick up your telephone and call the Yuba Center unit of the American Cancer Society at 742-2896. That's our local chapter of the American Cancer Society, 742-2896. Well, that's our program for tonight. I'd like to invite you to write to me at my dermatology and allergy office in Yuba City with your suggestions for areas and people that you'd like to see on this program. As you know, the Medical Explorer is a public service program, and I really do want to hear from you with your comments and suggestions. Please write to me at the Skin and Allergy Medical Group of Yuba City at 367 Del Norte Avenue, 95991. In my next program, the Medical Explorer will take you behind the scenes of more interesting frontiers of medical care practices here in the Yuba City and Marysville area. Till next time, I'm Dr. Robert Peppercorn, your Medical Explorer. Thank you for joining us tonight, and have a good evening.